नमस्कार। इंडियन पीडियाट्रिक जर्नल के हिसाब से मोर देन 2000 चिल्ड्रन डाई एवरी ईयर ड्यू टू लिवर फेलियर। दीज डेथ्स कैन बी इजीली अवॉइडेड बाय लिवर ट्रांसप्लांटेशन। तो आइए जानते हैं इस बीमारी के बारे में और पीडियाट्रिक लिवर ट्रांसप्लांटेशन से कैसे बच्चों का इलाज किया जा सकता है। इसके बारे में बात करने के लिए आज हमारे साथ देश के मशहूर लिवर ट्रांसप्लांट सर्जन डॉक्टर संजय गोजा सर हैं। Dr. Sanjay Goja has operated over 2500 liver transplant patients successfully. He is currently clinical lead and director at liver transplant department at Narayana Health. Welcome to Dr. Sanjay Goja. So to start with our questions, my first question is, sir, please elaborate about the major causes of liver failure in pediatric children.
The children with end-stage liver disease who need liver transplantation, the spectrum is different as compared to the adults with respect to the cause of the disease. The commonest cause in pediatric population is cholestatic liver disease, and among those it is the extrahepatic biliary atresia, which is the commonest cause of for the end stage liver disease and for the liver transplantation, need for the liver transplantation. It is usually present at the birth, and then if there's an operation which is called Kasai operation that needs to be done as soon as possible after the birth, and if it is delayed beyond 1 when liver goes cirrhotic, and these are the patients we see in our practice, the largest spectrum who need liver transplantation. Then other causes are usually metabolic liver diseases, like that there are metabolic diseases with respect to carbohydrate metabolism, which is called as glycogen storage diseases, amino acid metabolism, like tyrosinemia. Then there are diseases like Wilson's disease. These are some of the common causes of chronic liver disease in pediatric patients needing transplantation. Besides that, there's a huge spectrum of pediatric liver cancers who need transplantation. The commonest is the hepatoblastoma. Usually the patients need chemotherapy, and after chemotherapy they are assessed for whether they are fit for the resection or surgery removing that part of liver, and sometimes it is so extensive they need to have a liver transplantation. This type of cancer is different from what liver cancer happens in adults, which is called hepatocellular carcinoma. Although the HCC can occur in pediatric patients also, but usually it is some predisposing conditions which lead to hepatocellular carcinoma. The metabolic liver disease like glycogen storage disease, the tyrosinemias, even biliary atresia, they are predisposing factors for developing liver cancer, which is called HCC. It is different from hepatoblastoma. The hepatoblastoma is a childhood tumor which is very chemosensitive, and after chemotherapy the patient goes for liver transplantation or liver resection. These are some of the major causes of liver transplantation in children. So we have, at one end there's a totally different spectrum of the disease compared to the adults. But we can also see in the older children that liver disease can happen due to the viral infections also. Like we have hepatitis B viral infection, or sometimes acute liver failure occurs to some acute viral disease like hepatitis A or E. But besides that, the indications of the liver transplantation are usually different than adults.
थैंक यू सर। तो इसमें ये सवाल बनता है कि हाउ इज पीडियाट्रिक लिवर ट्रांसप्लांटेशन डिफरेंट फ्रॉम एडल्ट लिवर ट्रांसप्लांटेशन?
You see, pediatric liver transplantation, although same is the liver transplantation, but it is little different. You see, different with respect to the indications of the transplantation. As I said, the causes of the chronic liver disease or the decompensated liver disease needing transplant are different. The spectrum of the disease is different. There is a whole bunch of the congenital diseases, whether it is respect to the bile duct or it is the amino acid metabolism or carbohydrate metabolism. That indications are different than the adults. Regarding the need of the liver, how much liver is needed for the liver transplantation, it is also different. Adults being big in the size, they need larger size of the liver. Pediatric patient very small, and they need a small part of the liver. So like in the adults, we have deceased donor transplant where we put whole liver into the adult. In pediatric, it is not possible because we have to take a small piece of the liver. If we are opting for the deceased donor, we have to split that liver. Only a small part needs to be put in the liver, otherwise we will not be able to fit into the abdomen. Also, it causes what is called abdominal compartment syndrome. The liver, it will not work because there is too much compression inside it creates. So with the size has to be appropriate according to the size of the tummy or belly of the child, that it should fit inside his abdomen. And also because he is small, his metabolic need is small, so we need a really small part of the liver. If it is a living donor, again it is only the smallest part of the liver, which usually is the left lateral, or it is a small part of left side of the liver which we transplant. Sometimes even that part of the liver transplant, if it is less than 1 year child, we have to reduce that hyper reduced graft, or we have to do sometimes mono segment, one segment of the liver we have to put. These all things make pediatric transplant technically challenging operation because they are small, the vessels are small, then usually the flows are very less, so it is a technically challenging part. But the ray of light is there that pediatric patients have excellent post-operative outcomes. If we compare to 1 year or 5 year survival according to UNOS criteria or European registry or what we do here in India, the survival, whether it is 1 year, what is 3 year or 10-year survival, usually people will look at 10-year survival, it is much better than the adult transplantation.
That's really informative, sir. Now the question comes, what are the most common symptoms with which the patients approach you?
You see, as I said, the commonest cause of the liver transplantation for the liver disease is cholestatic liver disease, biliary atresia. So the commonest symptom which the child comes is jaundice. The usual symptom is the mother says that he had jaundice after birth. The doctor said it's a physiological jaundice which normally happens, but it didn't subside and it tends to increase. And then when they get the tests done, the ultrasound people usually say the gallbladder is not seen, and then we have suspicion it is a biliary atresia. The other common symptom is like failure to thrive. The growth gets stunted, the legs get bored, there's water in the tummy. These are some of the common symptoms which the child presents.
These seem to be severe symptoms. इसमें सर अब एक और सवाल आता है कि what constitutes the medical team which looks after liver transplantation in a hospital?
You see, the pediatric transplantation is, as I told, is a complex operation. So there are a lot of technical expertise which is needed for liver transplantation in pediatric population. It comprises a whole team of pediatric hepatologists, pediatric liver transplant surgeon, and then there's intensive care or ICU care is one of the very critical part of pediatric liver transplantation. And then there's a whole team of coordinators, counselors, dietitians, and whole anesthetists. So a whole bunch of that. But the main pillar of the pediatric transplant hospital should have is surgeon first, pediatric hepatologist, intensivist, anesthetist, pediatric anesthetist, and then coordinators and counselors.
Sir, now that we know that it requires such an elaborate team to operate a liver transplant patient, how would the patients come to know which is the most suitable hospital which can undertake their pediatric liver transplantation treatment?
You see, to take a decision that for any parent to get his child pediatric transplant done in a particular hospital depends on is that hospital presently doing pediatric liver transplants. Because if the hospital is already doing, that means they have all the facilities around for the pediatric transplant. And it is also very important that that hospital has ancillary pediatric care units also, like pediatric nephrology, pediatric cardiology, pediatric gastroenterology. They are also very important part of taking care pre-operatively and post-operative pediatric transplant patient. So if the pediatric transplant is happening in a hospital and the results are good, that is the way you will look forward. Any father, mother should look at forward they can get the child pediatric transplant done.
Sir, would you also like to share some advancements in the field of liver transplantation of late in India?
See, there are a lot of advancements which have happened and which are happening also. This mostly comes with respect to both, mainly nowadays, donor operation. Nowadays we are doing donor operation by robot or laparoscopy, and the donor can, the incision is very small, and this is a minimal invasive procedure. I mean, they can be up and about in a very short time. If the donor is mother, she needs to feed her baby post-op, so it is a leverage advantage for the family if they go minimal access surgery. The second advancement is, of course, the technicality of doing recipient operation, because as I said, it is a very complex. It is not only that the surgery, we have to make sure that appropriate size of the liver is put into the particular child with respect to his weight, with respect to his abdominal girth, with respect to his demand of the body. So they all constitute a complex array of the things which help in calculating the outcome in the children. So it is more like a AI type driven thing, that you have to pre-calculate the thing before we take somebody for the pediatric liver transplantation. So in all these things, there are a lot of things coming in this whole technology, and which are making pediatric transplant safe with better outcomes.
With these latest advancements, what is the success rate and post-transplant survival rate of liver transplant patients?
You see, the survival rate and post-success rate, as I told you, is very good in pediatric population, but it also depends how sick is the patient, how early he is brought for the transplantation, then also his nutritional status, performance status. So there are multifactorial things which determine the outcome in the pediatric population. And as I told you, like diseases like tyrosinemia, which has 30% chances of developing liver cancer, how advanced is the cancer? So they all fit into what is the outcome. But overall, if we take UNOS data or European registry data, the 1 year survival, patient survival, we all usually take in the medicine patient survival and graft survival. But for a common man, it is a patient survival. It is more than 80% 1 year survival. Even 10-year survival is now around more than 70%, and it is roughly catching up to 80%. Over the time, the survival rate has increased in the pediatric population. And in our own experience, we have seen, we are seeing patients who are like 5 years, 7 years and doing very excellent. You see, the children have a very high regenerative capacity, and they have a very high healing power. So once technically the transplant is okay in a pediatric population, they usually do excellently good. But what is most important thing is nowadays is regarding immunosuppression. In the earlier question, you asked me about the advancement. I just forgot in that immunosuppression, the advancements in the immunosuppression are a pillar in the increased survival of the pediatric patients. And there are a lot of innovations happening towards the immunosuppression part, because immunosuppression, as we know, they predispose to infection. Then in a pediatric population, over immunosuppression leads to development of sometimes a risk of developing second cancers, like there is post-transplant lymphoproliferative disorders, which is called PTLDs. So nowadays there is a shift towards the lower and lower immunosuppression, because the liver is immunocompatible. A child whose that immune system, it is in a very dynamic state, and once he gets new liver, over the time the body recognizes it, and there are less chances of rejection. So the immunomodulation forms a very cornerstone of the pediatric transplantation, and the trend is towards giving lesser and lesser immunosuppression, and over the years the immunosuppression is like one drug once a daily. That is the target.
Thank you so much, sir, for solving so many doubts of pediatric liver transplant patients. We would like you to share some words of wisdom with the patient families who are undergoing severe stress because of their liver failure patients.
You see, my personal recommendation will be for families is, if a child is having liver disease and the doctor says we need liver transplant, don't be afraid of it, for multiple reasons. Children have excellent outcome. Timely coming to a liver transplant unit is the corner of having a good, healthy, purposeful life. They live long life. There are people who have had transplant in the children. They are now part of football teams. They have doctors. They are in all professions. They live normally. And the girls have got married also. They have children also. So never ever look it in a negative way that this is over. There is a trend that, okay, this child is not well, maybe we do away with them and we get another child, we give birth to another child. But that is not which I recommend. The liver transplant has an excellent outcome. Pediatric population, the requirement of the liver tissue is very less. For a donor, it is more than 100% safe, because only a small part of liver needs to be taken out and put into the child, and child usually have a normal, healthy life. Timely coming to liver transplant unit and getting away with the negative thoughts is my personal recommendation for any pediatric population who need transplant.
Sir, can you please highlight few patient case studies?
If you ask me the spectrum of the diseases which I have personally done, we have done liver transplant, hepatoblastoma, liver, we have done even for HCC also, we have done in pediatric population. We have done lot biliary atresia, then metabolic glycogen storage disease with multiple liver tumor, then biliary atresia, post Kasai, then amino acid metabolic disorders, acute liver failure, Wilson disease. There's a whole bunch of the patients, whole spectrum which covers almost all the indications. We are doing transplant, and best part is we have done the donors by robotic also, and this is something person needs to see those patients and meet the families to believe it.
Thank you so much for your time, Dr. Sanjay Goja, to enlighten our audience. Thank you, audience, for watching our video till the end. If you have any questions or doubt, you can post it in the comment section or drop in your query in this mentioned number 9513 632 661. Thank you so much.